From China through Italy to the US, people clap from their windows, cheering the frontliners of our battle with the coronavirus pandemic. Healthcare professionals are out there 24/7 interacting with hundreds of individuals, asymptomatic and symptomatic alike. Despite having some protective measures and equipment, healthcare professionals of all people carry the unfortunate risk of becoming super spreaders. In China, more than 3,000 doctors were infected. The number of infected healthcare workers in Italy has doubled China's, and nearly 14% of China's confirmed coronavirus cases are medical professionals. Fighting the pandemic cost the lives of more than 100 healthcare professionals worldwide, with many describing their work as going into war unarmed. Besides the risk of infection, HCPs are likely to experience deteriorating mental health. The Journal of the American Medical Association recently reported that healthcare workers fighting the disease in China between January 29th and February 3rd suffered high rates of depression, anxiety, insomnia, and distress. So, amid rising numbers of cases, exhausting overhours, and a cloud of uncertainty hovering over a cure, how can you protect yourself at work? We created this 5-part course for you to learn more about how we can protect ourselves as healthcare professionals. Perhaps this can even help your friends and family better understand your daily challenges and support you along the way. Hundreds of millions have been social distancing for a couple of weeks, depending on their location, even months. This pandemic is changing our priorities, and its collateral damage is inevitable. But what is it exactly, and what are its implications on our healthcare system? Known to mankind since the 1960s, coronaviruses mainly cause respiratory tract infections in humans, which are typically mild, but as we all know now, it may result in severe illness. Earlier outbreaks, like in the 2003 SARS or the 2012 Middle East Respiratory Syndrome, include symptoms such as fever, cough, pneumonia, and potentially even leading to ARDS. While they all originate in animals, transmission from human to human only occurs with the SARS CoV and the SARS CoV-2 viruses, whereas MERS is primarily transmitted from animals such as camels and bats to humans, and possibly through interpersonal contact. SARS CoV-2 was thought to have originated in bats, whereas the pangolin was thought to be the intermediate host between bats and humans. But as more data became available, some scientists started considering the possibility that SARS CoV-2 is a chimera between two pre-existing viruses, the rat G13 of the intermediate horseshoe bat and the pangolin. Whether or not the recombination actually originated in bats is so far unclear. The coronavirus itself even has a distinct appearance. Its name derives from the glycoprotein spikes on its outer layer, which gives it the appearance of a crown or a halo in microscopic imaging. But how does its crown enable this sneaky virus to function so efficiently? Being an enveloped RNA virus, the coronavirus has an outer layer to protect its genome when it's not inside a host cell. The envelope contains spike proteins, which are necessary for host cell infection. When the spike protein binds to the ACE2 receptor, the virus is internalized by the host cell in a process termed endocytosis. Following ingestion, the membrane vesicle as well as the virus disintegrate, and the viral RNA is released into the host cell. In a complex biochemical process, the virus hijacks the host replication machinery to generate viral proteins and nucleic acids, which give rise to uncountable numbers of newly built COVID-19 causing viruses. The ACE2 receptor is widely expressed in human tissues, such as the lungs, liver, and parts of the gastrointestinal system. The deleterious effects associated with SARS CoV-2 infections are mainly exhibited in the lungs. When the virus enters the bloodstream and passes through the capillaries to infect epithelial cells, infected cells as well as the cells of the immune system secrete cytokines. The mediators activate additional cells of the immune system, such as B cells, which can produce antibodies that bind to the pathogen and mediate quick and efficient clearance. However, antibodies are only efficiently synthesized if the host has been infected with the virus before. In the absence of antibodies, clearance is delayed, and this perpetuates viral infection and cytokine secretion. The symptoms of fever, cough, and shortness of breath, and viral sepsis can be explained through damage to the alveolar epithelia by cytokines and activated immune cells. This process, known as cytokine storm, can result in acute respiratory distress syndrome or multiple organ failure. By now, most of us are familiar with the term exponential growth in relation to the virus, with rates differing between countries. The growth of this curve can be determined by the basic reproduction number, R0, which indicates how many healthy individuals can be infected by a carrier. For SARS CoV-2, this number is measured to be between 2.4 and 3.3. This means, in order to significantly slow the spread, 2/3 of infections must be avoided. Healthcare professionals come into contact with family and friends, hospital staff members, and of course, patients. When treating COVID-positive patients, HCPs risk getting infected too. Due to its long incubation period, an infected HCP might not even know they've contracted the virus. As they continue interacting with hospital staff, family members, and of course, more patients, they risk becoming super spreaders. Although SARS, MERS, and COVID-19 relate to each other genetically to some extent, they cause different diseases and behave differently. For example, while MERS was deadlier, SARS and COVID-19 are much more infectious. COVID-19's basic reproduction number, R0, which is used in epidemiology to indicate how many healthy individuals are infected by a disease carrier, is thought to be between 2.4 and 3.3, simply meaning that in order to significantly slow the spread, 2/3 of the infections must be avoided. Famously underestimated by some public figures to be just another flu, COVID-19 has also been compared to influenza. Both respiratory diseases cause a wide range of illness from asymptomatic or mild to severe disease and death. Both are transmitted by contact, droplets, and fomites. For example, objects like skin cells, hair, clothing, and bedding. However, the risk groups differ. Children are known to be drivers of influenza transmission, but their role in the COVID-19 transmission chain is still being evaluated. Current data suggests COVID-19 mainly affects older adults. According to the World Health Organization's Regional Office for Europe, the countries most affected by the pandemic are among the top 30 countries with the largest aging population. While the older adults are more susceptible to the infection, age is not the only risk. 10 to 15% of people under 50 have moderate to severe infection, with people in their teens or 20s requiring intensive care. There are even reports of people over the age of 100 who fully recovered after being admitted to the hospital for COVID-19, meaning underlying health conditions are a key factor. Furthermore, the case fatality rate for seasonal influenza is usually below 0.1%. While that of COVID-19 is still being evaluated, data provided by the World Health Organization shows the crude mortality ratio stands at 3 to 4%. So, despite all the similarities, COVID-19 is a novel virus, meaning it's doing something we've never experienced before. But how is it transmitted, and which protective measures should we take? While most HCP took droplet precautions at the beginning, it soon became evident that airborne precautions are necessary. Some even questioned whether or not it's possible to contract the disease from pets. The simple answer is no. Your dog is not likely to make you sick.
There is a route of infection via animals. For example, if a cat or a dog lives within a household of a person that has been tested positive and spreads the virus via droplets onto the fur of the dog and the cat, and another person would touch or stroke this dog and cat, then they can more or less transmit the virus and become infected as well.
Earlier this month, the U.S.'s Center for Disease Control and Prevention reported that RNA from the virus that causes COVID-19 was found in the Diamond Princess ship 17 days after its passengers had left. So what does this mean for hospitals? According to the New England Journal of Medicine, the virus is detectable on cardboard for up to 24 hours, plastic and steel for up to 3 days, and on the outer surface of masks for up to 7 days. In episode 5, we will discuss what this means and explore how correct procedures for disinfecting medical equipment can prevent hospitals from becoming a source of virus spread and to protect you at work. Transmission through interpersonal contact provides an even bigger challenge when working in hospitals. The virus has an incubation period that usually lasts 5 to 6 days within a spread of 1 to 14 days. Carriers of the virus are infectious during the whole incubation period, and probably about 8 days after symptoms began. Transmission can occur within less than 1.5 meters, some say even 2 to 3 meters of an infected individual, or through droplets or aerosols when an infected person coughs or sneezes. Naturally, this makes healthcare workers extremely vulnerable, as any treatment, from basic hygiene through nursing staff to advanced airway management and CPR, takes place closer than 1.5 meters to the patient. Recent studies show that not only sputum and swabs taken from the pharynx have viral material in them, but also 29% of the patient's stool. Urine has not been tested positive so far, and the virus could only be detected in 1% of patients' blood samples. Apart from avoiding transmissions of aerosols directly from one mucosa to the other, the most important vector of transmission is our own hands. Therefore, it is crucial to practice the well-known preventive measures. Make sure to disinfect or wash your hands and avoid touching your face before doing so. If possible, change scrubs after coming into contact with contaminated surfaces or people. When working on a patient and handling equipment or devices, having a colleague present to hand you the equipment and press buttons for you without coming into contact with the patient is a recommended practice to keep your ward clean, assuming that your colleague is in fact clean. Due to high exposure to the disease, to make sure healthcare workers do not infect one another, Matthias Malicek, MD residence in anesthesiology at the Medical University of Vienna says,
"We need to rethink the relation to our colleagues because now they could possibly be infected as well. So we need to keep safety measures up in the breaks as well. So we need to keep 2 meters of distance, and we need to keep wearing our masks even when only colleagues are in the room."
Although these efforts are effective to some extent, if one staff member gets infected, his colleagues are likely to catch the virus as well. To combat this, an increasing number of departments now split their staff in 2 teams, with a 2-week rotation allowing each group to sit out the incubation period to determine whether or not they are symptomatic or contagious. So, speaking of symptoms, contagion, incubation and such, how can we be certain if one is infected? Testing proved to be a productive method to slow down the spread and is commonly done using PCR tests or antibodies. PCR tests can be labor-intensive and rather slow. Results are produced after about 5 hours, and false negatives can occur up to 30% of the time, meaning they're more useful for confirming the presence of an infection rather than giving the patient the all clear. On the other hand, rapid antibody tests use blood samples of suspected patients and normally take around 15 to 30 minutes to deliver results. While antibody tests don't always pick up on early viral infection, they can indicate if someone has had contact to any particular virus, even if they are asymptomatic. But many countries do not approve these tests as we do not yet know how sensitive and specific they are. In episode 2, we will dive into the many complications of testing and some controversies surrounding the topic, including taxing working conditions and limited testing capacities for healthcare workers. So perhaps the one thing healthcare workers can rely on is personal protective equipment. To protect ourselves, our colleagues, and patients, it's important to follow the protocol of how to don and doff your PPE, as an unsafe removal of personal protective equipment can have hazardous consequences. In episode 3, we will share a thorough guide of the donning and doffing sequence, ensuring you never miss a step. But wait, if PPE is so important, how come social media is full of repurposed goggles and DIY masks? With a number of cases approaching 2.5 million, medical institutions are under immense pressure. Around the world, hospitals are reportedly converting entire buildings to treat positive COVID-19 patients, with some doctors admitting physicians are forced to put their specializations aside due to demand for everyone to learn how to handle ventilators, read indicators on monitors, and regulate pressure in breathing tubes. When the pandemic first hit New York, medical workers changed their personal protective equipment each time they visited an infected patient. But as supplies grew scarce, they were told to keep their protective gears on until the end of their shift. EU countries such as France, Spain, and the Netherlands reported shortages of ventilators, personal protective equipment, and testing kits, further increasing the risk that healthcare workers might become a source of the spread to the community, potentially even transforming hospitals into incubators for the virus. All this might be happening due to the fact that many healthcare systems around the world were caught unprepared for the tsunami of infection. According to The Lancet, the Italian National Healthcare Service suffered financial cuts of 37 billion euros between 2010 and 2019. In the UK, years of underfunding for the NHS places the country 35th in the OECD's hospital beds per capita ranking. Having had come into this crisis in such dire shape, what can we expect on the way out? Collateral damage at this stage is inevitable. Patients in need of care, sometimes even critical, for illnesses unrelated to COVID-19 are being shoved aside with resources untapped as hospitals continue to be overwhelmed by the coronavirus pandemic. We can say that this situation is similar to war. The lost lives among unprotected healthcare professionals further thinned out a workforce that was already functioning on low fuel to begin with. Lastly, years of cost savings in the past left fragile healthcare systems in developing countries vulnerable to the crisis, and their healthcare workers are likely to be victims of the economic crisis that is yet to come. Perhaps the devastating event is a wake-up call to the world and an opportunity to reevaluate priorities. As long as the healthcare system is lying on the stretcher, society cannot heal. While we cannot solve global problems of such magnitude using this video, we hope to make you feel understood and supported despite the difficulties. Stay tuned for our upcoming tutorials and share them with your peers all around the world to remind them that regardless of where you are, we are all in this together. We were as diligent as possible in providing accurate facts for this video. As the data on the pandemic keeps updating, we recommend staying informed through reliable and credible sources on a daily basis.